mobile bearing total knee arthroplasty. 4. Why we need mobile bearing knee? That's because of the issue of polyethylene wear, both at articular surface and at the undersurface. Here are 2 examples of polyethylene retrieved at surgery, both fixed bearing, both showing significant wear in the articular area. And here is a knee which I revised at 7 years. The surgeon had used a fixed bearing knee, severe osteolysis. And why did that osteolysis occur? Can we get the... This is on the table. You can see the amount of mobility that the fixed bearing has. The undersurface with so much mobility had produced undersurface wear and osteolysis. If we look at the articular surface wear first, we know that the contact stress which is so very high with a small area of contact comes significantly down as the area of contact increases. And here are 3 fixed bearing knees with different areas of contact and a mobile bearing with a large area of contact, which translates into a very low contact stress. And here are 3 fixed bearings far above the maximum permissible level for polyethylene. Why can't we have fixed bearing knees with very good contact area? Well, we can, but then we have a very high constraint force as the rotational movements are not allowed, which will translate into the loosening on tibial side. On the other hand, if we have a low constraint force, we will have a very small contact area and therefore high contact stresses, therefore the wear. So there is a kinematic conflict in fixed bearing knees. Whereas on the mobile bearing knee, we have large area of contact at the articular surface, and there is a decoupling of rotational movement at the undersurface, and thus there is low contact stress, low constraint force, and hence a kinematic agreement. This is the lab data which showed that there is 6 to 7 times less wear when you use mobile bearing compared to the fixed bearing knees. And this is the same thing shown for a same design of fixed bearing, that is PFC sigma RP and PFC sigma posterior lipped fixed bearing knees. In different flexion movement, there is a better contact area with the mobile bearing knee, which translates into lesser stress for mobile bearing during the range of motion. And this has also been shown in vivo by these studies in actually Oxford unicondylar knee, that the wear rate is extremely low, 1/10 of what we see in the femur, the total hips. Second issue is the undersurface wear, which actually is the current challenge faced with modular fixed bearing knees. The studies have shown that various types of fixed bearing knees with different locking mechanism all still have sufficient undersurface motion leading to fretting wear. Very little load is required to produce micromotion, and the same design of implant may have variable locking ability. Here is a control fixed bearing which has X amount of movement, but the implants removed at revision and autopsy show that the fixed bearing locking mechanism has failed further with 6 to 7 times more mobility at the undersurface. 67 retrieved tibial inserts. This study showed that the longer was the duration of the implant being in, higher was the undersurface wear, and this higher undersurface wear statistically significantly correlated with the osteolysis that occurred in the fixed bearing implants. So why is undersurface wear not a problem with mobile bearing implant? Because the fixed bearing trays are generally made from titanium, whereas the mobile bearing knees are made from chromium cobalt, and they are highly polished and therefore very little roughness. Dr. Ranawat told us in the morning, now we have a chromium cobalt plate for the fixed bearing, but they are still not as polished as the mobile bearing knees. Also, for the fixed bearing, the implant locking have improved, but the time only can tell how good they are. In addition, there are some other advantages, like there is more leeway for rotational alignment with mobile bearing knees. Also, if you look at the results of mobile bearing knees so far, there are a number of studies showing excellent survivorship at 10 to 20 years with no evidence of osteolysis with mobile bearing knee. But we must remember that all MBKs are not the same. It is the unidirectional mobile bearing, that is the rotating platform knee, which has a better wear than the multidirectional, which actually can have much extra wear. Here is the study showing excellent survivorship with the rotating platform knees as compared to many of the fixed bearing knees. Another study, 100% survivor at 12 years. And some more studies showing excellent survivorship for mobile bearing rotating platform type knee. This rotating platform knee, LCS, which has performed for so many years, has translated into posterior stabilized RP knee, introduced in India in 2001. And our study, which is now being considered by the journal for publication, has shown that at average 6.8 years, there is 100% survival with a 120 average range of movement and no osteolysis. It has also translated into a high flexion design, which we've used. Overall, it appears that mobility may be polyprotective with some better kinematic patterns. And therefore, in favor of mobile bearing, it is the lesser articular surface wear, lesser undersurface wear, better kinematics, and excellent long-term results. I leave you with this 13-year X-ray of one of my patients with bilateral mobile bearing LCS knee, who's been very active, sits on the floor, and has no osteolysis or any symptoms. Thank you very much for your attendance.